I am very happy to introduce Professor Yoto Yotov, who is one of the leaders from echocardiography in Bulgaria and also one of the experts of the good population in Bulgaria. Yoto?
Thank you. Welcome.
To discuss various aspects of this topic concerning the congenital heart diseases. And because this session is called Challenges which we encounter with in patients with congenital heart disease, one of these are the infections in patients with congenital heart disease. And I find it a really challenging topic nowadays, especially with the increasing number of patients that is being operated on. And I will start with the infective endocarditis in congenital heart disease. Well, this is happily enough not so common disease as all cases of endocarditis, by the way, and it has an incidence of approximately 11 cases per 10,000 person years in the adults, but which is much more than that of the general population, where the infective endocarditis is much rarely found. You see the comparison that it is 10 times higher the incidence than that of the general population. And in children, the incidence is approximately 4 cases per 10,000 person years, according to these studies. Another study more recently has found a similar incidence of 13 per 10,000 patient year incidence. Which is what is more important is not the actual incidence, but of course the chance of getting an infective endocarditis during your life, adult life, in patients with congenital heart disease. And this study from the Dutch registry, Concord Dutch registry, has tried to find out what is the observed cumulative risk to develop infective endocarditis from your 18th birthday up to the age of 40 and 60 patients, and according to the risk profile, of course. Their population was approximately half of them were males and a little bit more than females. Their mean age was 37, and you can see that there was patients up to 93 years of age, and the mean follow-up of the cohort was approximately 19 from 1 month up to 75 years. And what is more important and what is interesting to find is that by the age of 40, this cohort of CHD will develop, the chance of developing infective endocarditis is 2.5%, which goes up to 4.4% at the age of 60. Of course, if you're at a higher risk group, and we will see what is the high risk group later on, then this will double your chance of getting an infective endocarditis. Well, if you're in a lower group, the chance of developing such infectious complications is very rare, approximately 1 and less than 1% by the age 40 to 60 years. Our guess, the results and the observations from our guests from UK show that the incidence of infective endocarditis is constantly decreasing with time, and the implementation of the infective endocarditis guidelines does not affect this process of natural decrease of the incidence. But also something to be mentioned and to be taken into account is that the absolute number of cases does not change with time. Even the implementation of the guidelines does not affect positively this number of cases, especially for the prophylaxis of infective endocarditis. Which are the most common congenital heart disease, most common congenital heart defects that are prone to develop infective endocarditis? Of course, the most number of such cases was noticed in patients with left ventricular outflow tract disease, including the bicuspid aortic valve. The next is the shunt, those malformations which shunts. The tetralogy of Fallot and with or without pulmonary atresia is approximately 22%. Much less is in the other malformations, and complex congenital heart disease has a chance of getting only in 4% this complication. So the guidelines nowadays state very little about the risk of infective endocarditis in adult congenital heart disease. These are the last what is written down, and the risk of infective endocarditis is higher than in the general population, with marked variations between lesions, as we have discussed this. And recent studies confirm that the relatively high risk infective endocarditis in patients after valve surgery, particularly previous infective endocarditis and bovine jugular vein conduits. What are the most common etiological reasons for infective endocarditis? As in the general population, the majority of the cases are done by the streptococcal infection in 40%, but very closely followed by the staphylococcal infection in 1/3 of the population, and the others are much less found. It has to be discussed that in this series, the culture negative infective endocarditis were only in 10%. What is the entrance door for the infective endocarditis? If there is procedures that has been done in the majority of these patients, unfortunately, we found rarely such an entrance door. For example, dental procedure was found only in 11% of these series, while none was, as you see, almost 10 times higher in this situation. Other procedures was found to be present in 27%, most commonly because of cardiac catheterization, which is interesting because cardiac catheterization is considered to be a safe procedure for infection. But in these series, you see that in 4% there was this was the reason for the infection of the population. The Dutch group, which I have discussed, has tried to develop a prediction score of which are those who are at high and low risk of developing infective endocarditis. And we see that the male gender, the multiple congenital heart defects, the presence of ventricular septal defect, the presence of pulmonary atresia with ventricular septal defect, the presence of congenitally corrected transposition of the great arteries, also the bicuspid aortic valves, and some others have a great risk, as well as previous infective endocarditis episodes in childhood, as well as cerebrovascular accident. Gathering all these and adding all these points, you get a score, and then by dividing it by 10, you see that this is the risk of predicting the risk of getting this infective endocarditis up to the age of 40 and up to the age of 60. And you see that below 1 point, we have a relatively low risk, 1 or less than 1%, but if we get more than 3 points, the risk gets much higher. And if you have all the points, the risk, if the score is 7, then you have a 53% chance to get infective endocarditis by the age of 40 and 79% by the age of 60. The same group has developed more recently, based on the more observations, more patients' observation, that also the baseline, the prosthetic material that is used is also of importance. And if you have a valve-containing prosthetic, then we have a 3.5% higher chance to get this infective endocarditis, and this gives you in the new score 3 points, and then the same risk population is noticed. And as you can see that this valve containing has much higher risk of getting infective endocarditis compared to the other prosthetic valve, other prosthetic materials that I use, which is almost the same as if none has been used during the interventions. And this is of course giving a higher score if you get this valve containing prosthetic score with with a high chance of getting infective endocarditis. In pediatric patients, those are at highest risk if you have a previous episodes, implanted valve or other prosthetic tissue, cyanotic heart condition, structural congenital defects, heart transplant and valvular disease, and mechanical circulatory support. What is the prognosis if you get an infective endocarditis when you have a congenital heart defect? Well, you see that if you have this infective endocarditis, the chance of a new episode is not so high. For 3 years, it's 5%. But you can see that mortality, 3-year mortality is almost 20%. More than 20%, sorry, and the valve surgery, half of them will have a valve surgery, and combined death plus half plus valve surgery will have more than 2/3 of the patients with infective endocarditis, which means that when you get this infection, the prognosis becomes much more meager than if you have only the congenital defect alone. This is the hospital mortality in patients with infective endocarditis and CHD. And you see that the in-hospital mortality is 6.7%. And of course, only the survival is of up to 30 days is 5% mortality up to 30 days. In these patients, patient group of more than 700. And the median stay at hospital in this group was 36 days, from 20 to 55 days. The prognostic factors for patient mortality, the only significant factor that has been found, that was the presence of AVSD defects and the staphylococcal infection. Well, the hypoplastic left ventricle was almost, was marginally insignificant in these prognostic factors. Another group has tried to establish what are the bad prognostic factors for inpatient mortality, and in their observations, the age was such a prognostic factor together, and the most important, of course, was the presence of abscess, which is complicating the infective endocarditis when you have the chance of dying of 7 times higher, and almost significant was the presence of other emboli somewhere else. For the prevention, the guidelines both in Europe and in the United States states one and the same, that patients with congestive heart disease should be prevented if they have any type of cyanotic CHD, any type of CHD repaired with prosthetic material, whether placed surgically or by percutaneous techniques, up to 6 months after the procedure, or lifelong if residual shunt or valvular regurgitation remains, as well as patients with previous episodes of infective endocarditis. So you see that the prevention are more strict in this group of CHD rather than the general population. How about the pericardial diseases? This is even more challenging topic because there are not so much written down both in the literature as well as in the guidelines about the pericardial involvement in patients with CHD. So I will develop this, my second part of the presentation, in two. The one is the effects of the pericardium itself as a part of congenital heart disease. And the second is the pericardial involvement in patients with other CHD. So I will start with congenital absence of pericardium as a part of the CHD. This is a very uncommon defect, by the way, with a prevalence less than 1/10 per 10,000, but you should take into account that it is underestimated because most of the majority of the patients are asymptomatic and the findings are by chance, so the real prevalence is much, much higher. There is a definite male to female ratio of 3:1. Usually we have left-sided defects in 70%, while the right-sided are every 1 in 8, and complete bilateral absence of the pericardium less than 10%. The pericardial deficiencies are a result of failure of pleural pericardial membranes to fuse completely on one or both sides. 30 to 50% of patients with the congenital absence of the pericardium have associated another congenital anomalies like atrial septal defects, patent ductus arteriosus, mitral valve disease, tetralogy of Fallot, and sinus venous defects with partial anomalous pulmonary venous drainage. That's why in these situations you should look for a congenital absence of pericardium too. There's typical chest X-ray usually in the complete absence of pericardium. Then we have complete absence of the right border usually, and the heart is shifted leftwards and posteriorly. The elongated and flattened left ventricular contour is very typical, and this is the so-called Snoopy sign. And you may find a band of lucency between the heart and diaphragm, and between the aortic knob and the main pulmonary artery, which is the superposition of the lung tissue. The ECG usually shows poor wave progression in the precordial leads, as well as incomplete valvular branch block and sinus arrhythmia with the sinus bradycardia very much indeed. The echo is very typical from the left parasternal view. More of the right ventricle is seen due to this left shift of the heart. That's why you should be very careful not to misdiagnose a right ventricular enlargement, because in this case we have a positional situation and not enlargement of the right ventricle. On the other hand, the appearance of atria looks elongated like teardrops because they lose usually the support of the atrium, and that's why they are elongated and flattened and compressed. While on the other hand, the ventricles looks like more bulbous and with larger view, especially of the right ventricle, as we have discussed. And there is usually exaggerated cardiac motion during systole. The absence of pericardium can be easily seen on the CT and the MRI. And in this case, the arrow shows also the interposition of tissue from the lungs between the aorta and the pulmonary artery. As far as the pericardial effusions in congenital heart disease, there's some case series that have been described, starting from the 1960, where six cases, 5 with ASD and 1 with pulmonary stenosis, were noticed by this American group. 3 of them developed constrictive and fibrinous pericarditis, and 3 of them has large pericardial effusions due to heart failure. Another group has developed and discussed about 2 cases with ASD and large pericardial effusion. And there's also cases of AVSD with Eisenmenger syndrome, which has been discussed in the previous lecture, where in the Eisenmenger syndrome, we may also notice a pericardial effusion. Pericarditis and pericardial effusions in children are not so common. In this series, use more than 11,000 patients with pericarditis and pericardial effusion in US. You find that in childhood, the majority nowadays after cardiac surgery, so they are post-pericardiotomic syndrome. In 54% was the same situation, including surgery for CHD, while the neoplastic renal, rheumatological, and idiopathic were much rarer. Post-operative pericardial infusion after CHD surgery was noticed in 23% of this group of more than 300 patients with 30% cyanotic defects, and the usual appearance of the pericardial effusion was on the average 11 days. That's typical in childhood, that you find it usually during the second week after the operation. 56% of them has moderate to large effusion, but only 23% of this series were symptomatic. More often in large than mild to moderate. Of course, you can expect this. More often they were found in Fontan type procedures in 60% compared to the others. And you can see this on the right, and more often in females than in males. Warfarin treatment conferred 4 times higher risk of getting a pericardial effusion in this group. Another larger group with including more than 1,000 children with within 1 month after the operation in the Netherlands found that in 133 patients, the pericardial effusions were clinically significant. 24% was the incidence of pericardial effusion in the whole population, and only 11 were clinically relevant pericardial effusions. The predictors for the occurrence of clinically relevant pericardial effusions was younger age, body surface area, right-sided heart defect, history of previous operation, cardiopulmonary bypass use, duration of CPAP postoperatively, and of course, inotropic use. And because we are in the COVID-19 situation in Bulgaria and everywhere in the world, it's interesting what is the incidence of pericardial effusions in patients with congestive heart disease. In this Italian observation done last year, it was the pericardial infusion was found in only 1 patient out of 76 with COVID-19 suspicion and CHD, and those who was with confirmed COVID-19, which were only 9%, there was only 1 patient with pericardial effusion, which was much lower than other complications like heart failure, palpitations, arrhythmia, and even stroke. In conclusions, ladies and gentlemen, infective endocarditis and pericardial effusions are found more often in patients with CHD than in the general population. They have similar clinical presentation like the other populations, but they usually the presence of the infection worsens the clinical course of the CHD, and the early diagnosis through multimodality imaging can lead to due-time treatment and improves prognosis. Thank you very much for your attention.
Thank you, Professor Iotov, for the very clear and very nice presentation. I think there is many questions about how to treat the patient with the pericarditis and adult congenital heart disease.
Well, I said that unfortunately there is nothing in the guidelines nowadays. I have scrutinized all the guidelines which are available nowadays on the question of pericardial diseases, and there is nothing that is mentioned about the difference in patients with congestive heart disease in adults. In the pediatric population, there are more data about this, and what is said is usually that the treatment of the viral, for example, pericarditis, which is the most common, of course, as in the other population, the treatment is just the same with the involvement mostly of the non-steroidal anti-inflammatory drugs. Colchicine also is used, and in cases, more severe cases, very carefully corticosteroids. But the treatment is just the same as the other ones, and it is according to the current guidelines for the general population with pericarditis, nothing special.
Okay, thank you. Professor Lee, do you have any comments?
Sorry. So I think this is a really interesting topic. We call the challenging sessions for Professor Yotov. You know, I learned a lot from your talk. Endocarditis actually still one of the headache for us. It still carries a high incidence and a high mortality. I saw in one of your slides, you think the AVSD is the same as one of the poor prognostic marker. What do you think the potential reasons for it?
Well, I don't know what may be the potential reasons, but this was only in one observational series, and you know that sometimes the statistics may be just the play of chance for this explanation of why there was a higher mortality in this population. But I don't think that there are some reasons for this. I cannot explain it from a biological point of view. I think that it is more the play of statistics.
Thank you.
Do you think so?
Yes, I think maybe potentially these AVSD patients have Down syndromes. They do have a low immunity, isn't it?
Yeah.
I don't know whether they have explained that or not.
Well, I can't remember that there was. Well, there are some, of course, some also observations about this Down syndrome and infective endocarditis, but only a few cases. I think in this particular case, it's only the place, the role of chance and the statistics, of course.
Thank you. Thank you.
Thank you. There is one question in the chat. I think we could make the comments. It's possible to estimate the left ventricle diastolic function accurately on echo in shunt lesions.
This is very hot topic. You know, with the shunt lesions, all the conventional criteria what we have in the guidelines, I don't think it works. Actually, in general, in ACHD, this diastolic criteria is not very accurate in our patient population, because if you think you're using the TDI parameter at the septum level, if the patient had a patch there, how can you expect E wave will be high? So there is a lot of the factors that influence it. Shunt, of course, if left the right shunt at ventricular level, the E wave will be higher. So I don't think this conventional parameter is very, very useful. But then the general rules, like if you have patients with a shunt lesion, you expect both left ventricle, left atrium should be dilated. But then you have only atrium dilatation, ventricle not dilated. You should think why, that possibly ventricle cannot dilate. So these kind of general rules can be used. I really don't know how to accurately assess diastolic function when they have a really shunt. We're just using the impression, say, is atrioventricular equally dilate or you have disproportional atrial dilatation and no ventricular dilatation. If you can't explain it, then think of diastolic dysfunction.
The things even get worse if you have a pericardial effusion, where then again, it's much more to rely on the E-wave, for example, in the mitral blood flow, because of the effect of the pericardial effusion, especially with inspiration and expiration, and then the things get even more complicated.
Exactly true. Exactly true. A lot of unknowns, really.
Yeah.
Thank you.
If we want to use the new parameters like untwist rate and the timing for the late untwisting, it's very difficult from the normal heart to go directly to adult congenital heart disease for many of the situations.
Exactly.
Yeah.
Concerning the twisting and untwisting, you should have to take into account that the pericarditis, for example, impairs the twisting of the heart also. So this should be taken into account when you have a pericarditis and pericardial effusion also.
Yes, yes, you're very true.
Yes.
Okay, so
talk.
Thank you, Yoto. I hope that we will stay until the end of this session and we will continue. So the next topic is the pregnancy and adult congenital heart disease. I'm close my video because I'm going to the next computer to present my presentation. I think you see my presentation. So the
very good.
The pregnancy is very crucial problem in a patient with the adult congenital heart disease, and the risk of pregnancy is going to be very growing because in the last years we have many of the patients that growing up until the adulthood, and this is the problem is really increased. So I'm starting my presentation with one very interesting clinical case, which is coming a couple of years before in our hospital. This is the 23 young female with Marfan syndrome. She is presented at 11 weeks of pregnancy. The medication that she take during the pregnancy is started with the metoprolol and prenatal vitamins. The echocardiography, it's with the normal left ventricle left sides and function, mild aortic insufficiency, but when we look at of the aorta, it's 7.7 centimeters. It's quite huge and quite neglected in the last years, and she never has been from the young stage of the childhood is visited the cardiologist. So the high risk for aortic rupture here is the present. Cardiac we sent especially this woman for the cardiac surgery, and was performed aortic root replacement at the 13th week of the pregnancy. The post-operative, the pregnancy was complicated with the spontaneous miscarriage, and this is performed. So the women with the heart disease are very increasing in the obstetrical offices in the last year. And the complication during the pregnancy is migrated from 1 to 4% for the pregnancy that developed the pregnancy. Many women are postponing the pregnancy until late in the life because this is the chance to increase the incidence of the hypertension, diabetes, hyperlipidemia, and coronary artery disease, which is also going to be the problem during the pregnancy. The major causes of the non-obstetric maternal morbidity and mortality, it's not now nowadays the rheumatic heart disease, but is the congenital heart disease. Many of the people who survived during the age of these last years and the good pediatric cardiac surgeon, we can see that we have around 90% from these small children going to be for the adults in nowadays. The most frequent complication in the women, such as the pulmonary hypertension, especially Eisenmenger syndrome, severe left ventricular outflow stenosis, cyanotic congenital heart disease, orthopathy, Fontan procedure in systemic right ventricle, atrial switch and congenital corrected transposition could carry a very high risk for the pregnancy. Most frequent complications during the pregnancy and delivery are the development of heart failure, arrhythmias, bleeding or thrombosis, and rarely the maternal death. The complications of fetus are premature and low birth weight, abortion, and stillbirth. So the risk stratification is mainly for this kind of the group, and because we could have the wellness of the woman with the heart disease, we must have enabled to save the pregnancy, and when is the safe to pursue, and to help to ensure the mother and the child to be very healthy after these months. So nowadays survivors of the patient, the small baby for the congenital heart disease in the growing population going for the crypto to old age, and more adults than children living with the congenital heart disease now. We can see that this is mainly the population, around 85% of the adult congenital heart disease have complex disease, not only one disease. But this is the adult Alabama adult congenital heart program distribution of the lesions of the congenital heart disease, and many of these patients could follow for some of the complications that could find after the operation. So each patient's circumstances is very unique when we look into about the pregnancy with the adult congenital heart disease. We must educate the patients for the inhibitor to be very helpful. But since of the 60% of the patients after 18 ages, preconception counseling isn't always possible. So because we lost them to follow. How is going to change the cardiac physiology during the pregnancy, and what we must to know that from the first to the last trimester, this 40 weeks to the delivery, there we have anticipated changes during the pregnancy. We could develop a relative anemia, changes also in the circulatory system, decreases of the peripheral vascular resistance, increasing the heart rate. Particularly in the third semester, we could find increasing of the cardiac output from 16 to 80%, increasing the blood volume by 40 to 50%. During the labor, we could have actually very different status that during the labor we will find the increasing of the blood volume with uterine contraction around 30 to 500 milliliter, increasing of the venous return. Blood loss during the delivery, it's around 40 to 500 milliliter in vaginal delivery and around 1 liter per cesarean section. These hemodynamical changes, it could be very difficult for especially for the patients with the congenital heart disease to pronounce. Could SECTOTS is a reintroduced help of this kind of population of women. This can potentially decrease the anxiety and the pain and the stress related to the contraction, but it's possible to add additional risk from the anesthesia, increase the blood loss, the mechanical ventilation, and that wise it's very rarely indicated for the patients with the adult congenital heart disease. The changes after delivery also could perform. We could increase the preload after the lower body. Losing of the blood is mainly continue to increase the in cardiac output. Risk is the time for the pulmonary edema, and this is the ongoing the fluid shifts for the several days also. We must to assess the risk of the pregnancy because this pregnancy is the stress test for the heart of the woman, not only for the congenital heart disease, but for every woman. So what is my risk for the heart problem? This is the main question that the woman could ask the cardiologist when she is going to resolve the problem. Maternal cardiac disease and the risk assessment, the complication, it's around the 1 to 4% for the normal health woman in the West countries. But when we have the pregnancy with congenital heart disease, increasing the risk for the cardiac complication like developing the heart failure and high mortality if we have the patients with the very high stage of the heart failure 3 or 4. This is increasing the risk of the mortality around the 7% and the morbidity around the 30%. Performing the pre-pregnancy risk is very mainly and basically because we could perform the exercise, the capacity with the exercise stress test, metabolic exercise test. Also, the history of the heart failure, the arrhythmia, the hypertension, diabetes, smoking, lipid history, and family history for the heart disease could be increase the risk of during the pregnancy. ECG and the echocardiography is the mainly that we could use it for assess the anatomy, lesions, severity, and hemodynamics. Cardiac MRI is also useful for before the pregnancy. So the pre-pregnancy counseling is ideal, and this is going for the two direction: the assessing for the maternal risk certification and the risk for the fetus. Because the history examination and the different examination could perform before the pregnancy is very important. We could define here the endocarditis prophylaxis and make the recommendation for labor and delivery. The risk for the fetus is also not so smaller than for the mother. The likelihood of the congenital disease, the fetal icon genetic counseling is very important. Also to eliminate the teratogens from the therapy if the mother is still take some medication. Consider needs for the procedure from the surgery, also for the lifespan functional status of the mother. There is certification of the pregnant woman during the cardiac problems. This is the one of the study which was published in 2001. This is the CARPREC investigator group from the Canadian Society of the Obstetrician and the Cardiologists. This is the certification of the pregnant cardiac patient and looking for the retrospective outcome analysis in the congenital heart disease. Actually, the patients with the congenital acyanotic and cyanotic conditions like shunt tetralogy of the fellow, double orifice right ventricle, aortic coarctation, transposition, bicuspid aortic valve, Epstein's anomaly, pulmonary stenosis, Marfan univentricular heart, congenital cyanotic condition some valvular disease, cardiomyopathies, ischemic heart disease, pulmonary hypertension, arrhythmias, and conduction disease are involved in this study. And the main events that they look at about during the pregnancy, this was the pulmonary edema, symptomatic arrhythmia, stroke, cardiac arrest, death. Looking about this calculator and the risk stratificator for the CARPREC study, we could show that we have 4 risk groups, and when we stratify the patient for the predictor for the present during the maternal complication and for the cardiovascular disease during the pregnancy. If we have 0 point from anamnesis of the prior cardiac events like heart failure, transitive ischemic attack, stroke for pregnancy or arrhythmia, or some of the signs of the heart failure, left heart obstruction, or some valvular disease, reduces systemic ventricular systolic function, ejection fraction below 40%. We have around 5% of the risk of the cardiovascular maternal complication. 1 point only increased the risk with to 27%, and more from the 1 point is the 75% of the risk for developing the cardiovascular complication. There is another risk classification proposed for the WHO, that the modified classification cardiovascular risk of the principles for pregnancy, the risk class 1, 2, 3, and 4. This is the risk of the pregnancy for the biomedical condition. The risk class 1 is no detectable increased risk of maternal mortality and no mild increase or morbidity. The risk class 2 is the small increased risk of maternal mortality or moderate increased or morbidity. Risk 3 class is significantly increased the risk of maternal mortality and severe morbidity. Expert counseling required in this class if pregnancy is dedicated upon intensive specialist and cardiac obstetrician monitoring needed through the pregnancy, childbirth, and the puerperium. And higher class 4, extremely high risk of maternal mortality or severe morbidity. Pregnancy is 17 hours indicated in that case. If pregnancy occurs, determination should be discussed. If pregnancy continued, care for class 3. WHO recommended not have pregnancy in that condition, pulmonary artery hypertension in any case, several systemic ventricular dysfunction with left ventricular ejection fraction below 30%, previous peripartum cardiomyopathy with any residual impairment of the left ventricle function, severe mitral stenosis, severe cyanotic aortic stenosis, Marfan syndrome with aorta dilated more than 45 mm, aortic dilatation over the 50 mm in aortic disease associated with bicuspid aortic valve, native severe coarctation. So estimated risk and where to deliver, this is the next problem that we could divide during the pregnancy. If we have the class 1 or CARPREC score 1 or 0 or Zahara score below 1.5, delivery could be performed in community hospital. But when we have the class 2 to 4 or CARPREC score more than 1 and 1 plus, and Zahara score more from 1.5, this will be delivered in the regional center with specialists of congenital heart disease, cardiac surgeon, anesthesiologist, obstetrician on the high level for the consultation. This is one of the example from my clinical practice. This is the 33-year-old female with the history of the tetralogy of the fellow. She has operated on the 3.5 years and very well now with the post-operative long period. She takes metoprolol with a small palpitation, and she is coming in our room with the slight symptoms of the heart failure. Present to discuss the having a baby. For the echocardiography, we find severe pulmonary insufficiency and right ventricle hard to visualize. We send this lady to cardiac MRI, and right ventricle function was around 42%, with severe right ventricular enlargement and severe pulmonary regurgitation. Actually, long-term complication for the tetralogy of law, the repair tetralogy of law, could be pulmonary insufficiency, right ventricular enlargement, right ventricular dysfunction, tricuspid insufficiency, left ventricular dysfunction, branch pulmonary artery stenosis, arrhythmia, aortic insufficiency, aortic root enlargement, sudden cardiac death. So the score for when we look at about the Sahara scoring, the risk was around total score we find this lady with around 30 points, and the risk is around 75% to develop the higher cardiovascular enlargement. Why it's very important to send to have this consultation before the pregnancy? Because many of the tests and procedures are more safely done. We could optimize the patient's health prior to getting the pregnant and to ensure the medication are very safe during the pregnancy. All aspects of care are available before the pregnancy. We could have the multidisciplinary team for the approach, how to deliver and how to going to develop this pregnancy. We need to have adult congenital and pediatric cardiology consultation, obstetric also and anesthesiologist. When we have the heart failure development and pulmonary hypertension, we need also the specialists from that field and also of the genetics. This is another clinical case with our practice. This is the 21-year-old woman. So she came in our lab with the pregnancy in the 13 gestation weeks with the tachycardia and weakness. They performed echocardiography and find that it's not very well visible here, but very high signs for the high blood pulmonary arterial pressure, hypertension, around 65-70 millimeter per mercury, and that could see there is, even from the transthoracic echocardiography, is the high, very big ISD. We operated this woman, and especially the pregnancy was discontinued, terminated, and this lady came 18 months after the cardiac surgery, 10 weeks on the pregnancy again. The pulmonary arterial hypertension is 25 millimeter per cure, which is the very slight tricuspid regurgitation, and there is slightly left to right shunt in this clinical case. We classified this lady for the lower level of the cardiovascular incidence during the pregnancy, and she developed a couple of months ago actually the pregnancy in our. So, like the summary, the woman with the simple congenital heart disease or without significant hemodynamic or rhythm impairment must have uncompleted course of pregnancy and no impact of the subsequent cardiac state. However, some lesions such as the ISD secundum, even when operated, aortic coarctation, dilated or hypertrophic cardiomyopathy or carcinogenic defects may present serious problems with arrhythmias in the systemic and the pulmonary hypertension. I just want to go over a very short briefing about the how to we could monitoring the pregnant woman during the pregnancy when we have with the congenital heart disease should become very attended. The cardiologist must explain the condition with the congenital heart disease and even to obstetrician, and provide information of any symptoms in the physical change by the monitoring during the pregnancy in the prenatal period. Actually, the periodic checkups for the pregnant woman is generally consistent a couple of visiting of the cardiologist. For the moderate to high risk of congenital heart disease, cardiologists must check mother more closely. Also, the first visit must be around 58 weeks of the gestation. Nearly the 20 weeks, then the follow-up of the same visit of the obstetrician schedule, if it's possible. If not, we recommended this to be under 24 and 35 weeks of gestation and before to delivery. So, the take-home message: the majority of the pregnant women with the disease of referral must be sent for the referral centers. Maternal deaths are very rare, as the Mengele syndrome also is not recommended to send it to the delivery even for the pregnant. Looking for about the severe pulmonary vascular disease, also for the Marfan syndrome, aortopathy, is not recommended to delivery. Congenital heart disease increases the risk of morbidity, and also if there is the presence of the heart failure, arrhythmias in the stroke is also with the high risk of the pre-delivery. Cardiovascular complication occurs in more than 11% of the pregnant patients. Should be followed very closely and in the tertiary care center by the cardiologist, high-risk obstetrician specialists, and evaluated in advance by anesthesiologists. Before to close my presentation, I give it this very small remembrance from the one of the last clinical courses of the Professor Wiley and Professor Ho in Royal Brompton Hospital, where it was more possible for me to visit them. Thank you once again for this very nice course. And just to remember that the next course on the Royal Brompton Harefield Hospital will be set next September 13 to 14. It's a very interesting and very enjoyable for everyone to visit there. Thank you.
Thank you, Professor. It's such a comprehensive talk, and I can see you do see a lot of challenges because the lady comes with a pregnancy and a heart lesion, isn't it? I saw you had a patient with this Marfan, the root really scary without pregnant when you find the root over 7 centimeters.
Yes, it's very tricky because she was not visited the cardiologist from 5 to 6 years because actually the system in Bulgaria changed in the last 20 years, and some of the patients going abroad, some of them don't live in Bulgaria, and they lost the contact with specialists from the congenital heart disease. Actually, until 18 years, here it's very strictly recommended to visit the pediatric cardiologist, but after 18 years, it's very difficult to follow up the patients because they are going to the adult cardiologist, and many of them is very difficult and very strange to follow up the patients with this complication.
Yeah.
If there is the pregnancy, it's going to be very difficult.
I think you do need a pre-pregnancy counseling clinic, isn't it? To educate, advise all the patients had previous cardiac problems come before pregnancy for a general check to assess their risk. Then you can avoid a lot of traumatic problems.
Yes, this is
a question here for you as well. In the chat box, Prof, can you read? Or?
in unoperated tetralogy of Fallot, in patient came in pregnant the gestation 13 weeks. Previously, the follow-up saturation 86. NIHA 1, is it okay to continue the pregnancy? I think it's the pregnancy must be discontinued in this way because we have very low level of the oxygen saturation and NIHA 1. I think there is also increased pulmonary hypertension, and this kind of patient, it's very difficult to follow up during the pregnancy. It will be the big problem for the mother and for the fetus. And I think it's until the couple of weeks, 15 weeks before the 20 weeks, maybe we must discontinue this delivery.
Thank you. I totally agree. The situation is low, isn't it? Even you don't terminate, there is a risk they will have spontaneous abortion in a borderline situation. We usually see less than 85%. They cannot have a live baby. So this is really borderline in the early gestation. High risk. Thank you.
Yes, it's must be discontinued before the going to grow up the baby. Okay.
Thank you very much. I think we still have some more exciting topic.
Yes.
Introduce some.
The next topic will be the role of the cardiac MRI in adult congenital heart disease. And it is my pleasure to introduce Dr. Nila Chaudhuri. She is coming from the West Virginia University, United States. And it's a very good expert in adult congenital heart disease and cardiac MRI.
Hello, everyone. I'm Neeta Ray Chaudhuri, Assistant Professor and Director of Pediatric Advanced Imaging and Cardiogenetics at the Division of Pediatric Cardiology at West Virginia University, USA. So my talk today will focus on the role of cardiac MRI in adult congenital heart disease. I have no financial disclosures. The objectives of my talk today will be centered on the recommendations for use of cardiac MRI from the 2018 guidelines for adult congenital heart disease. I'll be discussing on why cardiac MRI in these patients, and I'll discuss specific congenital cardiac lesions and the utility of cardiac MRI in these lesions. So these are the 2018 guidelines for management of adult congenital heart disease, which will be my reference throughout this talk. So why cardiac MRI in these patients? Usually we all know in older and larger patients, there are poor acoustic windows by echocardiography. There is less field of view, and thoracic vasculature is often more challenging to see than intracardiac anatomy. It is a non-invasive alternative to diagnostic catheterization with no ionizing radiation exposure, and it is cheaper. It enables us to do assessment and serial evaluation of ACHD patients. Standard protocols by cardiac MRI are usually modified to assess these patients, and it is recommended that cardiac MRI in these patients should only be read and reported by physicians with specialized training in congenital heart disease. So cardiac MRI in these patients not only offers us anatomic details, but we are able to assess physiologic details as well. It allows the assessment of extracardiac defects like coarctation of aorta, aortic aneurysms, abnormality of the thoracic, arterial, and venous anatomy, and connections. And we can elucidate uncommon, complex, and variations of congenital heart disease. Cardiac MRI has been found to be so useful in these patients that there's work in progress to modify pacemakers and leads to be able to do the study. So far, most are still not MRI safe, and cardiac CT is usually done in these patients. The specific cardiac lesions that I'll be touching on today are tetralogy of Fallot, transposition of great arteries, coarctation of aorta, aortic anomalies, pulmonary venous anomalies, systemic venous anomalies, and single ventricle physiology. So starting with tetralogy of Fallot, which is the most common form of cyanotic congenital heart disease, consisting of pulmonary stenosis, RV infundibular obstruction, anterior malaligned VSD, and overriding aorta and right ventricular hypertrophy, as you can see in this image. And this is looking at different types of repair in tetralogy of Fallot. So a shunt can be done, as you can see on the right, as a palliative measure between the aorta and the pulmonary artery to provide pulmonary blood supply until complete repair is done. At the time of complete repair, the shunt is then taken down. Or what is more commonly preferred now, which is a complete repair on the left, which tends to be done earlier in life, where the VSD is closed with a patch, the RV muscle bundles below the pulmonary valve are excised, and pulmonary valvotomy or repair is done. If the pulmonary valve annulus is hyperplastic as well, then a transannular patch like this is placed across this region to widen the pulmonary artery. And sometimes a non-transannular patch and valve sparing repair is also done. So the consequences of tetralogy of Fallot surgical repair over time are, so with relief of RVT obstruction, pulmonary regurgitation develops, there's RV volume overload as a result, stretching of the tricuspid annulus and tricuspid regurgitation, atrial dilation, and atrial arrhythmias. On the other hand, there can be residual RVT obstruction, branch PA stenosis, and RV pressure overload and right ventricular hypertrophy. And we'll see examples of both of these. These patients can also develop aortic root enlargement over time as a result of the physiology and aortic regurgitation. So the goals of cardiac MRI in patients with tetralogy of Fallot include longitudinal follow-up in these patients. It is like a one-stop shop, and it's the most comprehensive non-invasive exam. Starting in adolescence, it is recommended to follow up with cardiac MRI in these patients every 3 to 5 years. There is good reproducibility for key parameters, which supports clinical decision-making for pulmonary valve replacement and risk stratification, ultimately. So cardiac MRI assessment in tetralogy of Fallot includes quantitative assessment of LV and RV volumes, mass and stroke volumes and ejection fraction, regional wall motion abnormalities, anatomy of the RVOT pulmonary arteries, aorta and aortopulmonary collaterals, quantification of pulmonary insufficiency, shunts through residual defects, comparison of branch pulmonary artery flows and cardiac output, and myocardial scars from previous surgery. So for assessment of accurate RV volumes and function, a short axis stack is very helpful, as you can see. Here you can see in this patient that the right ventricle is significantly dilated. The right ventricle is the anterior ventricle to the left of the image, and there is an aneurysmal RVOT on top due to the transannular patch placement. The short axis is also very helpful for assessing left ventricular function, as these patients can develop LV dysfunction over time, secondary to ventricular interdependence. So this is an RV 3-chamber view in two patients with tetralogy of Fallot repair. This shows, as you can see in both the images, so on the left side of the image on the top is your right atrium, and then the tricuspid valve leading into right ventricular inflow, body of the right ventricle, and then the RVOT on the top of the image on both on the top right. And you can see in both patients, there is an aneurysmal RVOT that can be seen. So this view is usually very useful for assessing the right ventricular outflow tract. And this is a patient of ours. I wanted to show how useful it is to obtain an axial stat in this patient, and where you can see everything all at once. And as it will scroll through, you can see this patient has a right aortic arch with mirror image branching. There is a dilated aortic root in this patient. And as we keep scrolling forward, you can see the branch pulmonary arteries, the left pulmonary artery is dilated, and the RVOT is aneurysmal, and then this leads to an enlarged right ventricle. So on the other hand, like I discussed earlier, this is a short axis stat of a patient of ours with residual pulmonary stenosis. The right ventricle is anterior ventricle, like I said, in the left beneath the sternum. And you can see the loss of signal at the upper portion of the RVOT, which denotes pulmonary stenosis. And then this right ventricular wall is hypertrophied, as contrast to the previous case. Okay. So the axial plane is very helpful, like we saw in these patients, to assess the aorta as well as the branch pulmonary arteries by cross-section. As you can see in this example, there's ascending aorta at the level of the pulmonary artery bifurcation is dilated, and in this patient, the pulmonary artery, branch pulmonary arteries are hypoplastic as well. The degree of pulmonary insufficiency can be assessed by obtaining main pulmonary artery flow in the sagittal view. And as you can see from the graph, the forward flow in systole is above the line and the regurgitation is below the line. Regurgitant fraction can be calculated by dividing the volume of pulmonary regurgitation over the stroke volume, and anything greater than 40% is free pulmonary regurgitation. Coronary artery imaging is also very important in these patients. It not only gives us an idea of the anatomy, but also very important for interventions, both transcatheter and surgical, around the right ventricular outflow tract. So 3D contrast MRA is very helpful in these patients. So on the left, you can see a 3D contrast MRA of branch pulmonary arteries. And it is very useful to look at the anatomy of these by MRA. And then on the right, you can see the right ventricle with a very aneurysmal RVOT. So again, very useful to use 3D contrast MRA in these patients. So moving on to transposition of the great arteries, I'll talk about atrial switch repair first, which is either the mustard or the Senning procedure. And this consists of, and we'll go back to the image, a systemic venous baffle, so both the SVC and IVC are baffled and diverts blood flow to the mitral valve. And then a pulmonary venous baffle is created of the pulmonary valves, and you can see the direction of flow through the pulmonary veins, that diverts blood flow through to the tricuspid valve. So the goals of cardiac MRI for atrial switch repair are focused on expected long-term post-operative complications. So longitudinal follow-up and change in function can be assessed. Assessment of volumes and function are very essential for the systemic ventricle, which is the right ventricle, and also for baffle leaks. Baffle stenosis can be assessed accurately. Usually SVC is seen to be more commonly stenosed than IVC in about 5 to 15% of cases. And then the subpulmonary area can be assessed well, so essentially the LVOT. And QPQS can be obtained to assess for the extent of baffle leaks. So the four-chamber views and stack of the four-chamber is very helpful in these patients and shows the pulmonary venous baffle, as you can see here. It's labeled and can assess for any leaks or stenosis in this baffle. And any level of pulmonary hypertension in these patients should lead to suspicion for pulmonary baffle stenosis. Systemic baffles can be assessed from the coronal view, and here we can see the SVC portion, otherwise known as a superior limb. These patients are prone to atrial arrhythmias, and so the SVC venous channel pathway is required, a patent pathway is required for transvenous pacing. And then this is the IVC baffle, or the inferior limb, which is also seen from the coronal view. The IVC baffle stenosis is less well tolerated than SVC baffle stenosis and can result in elevated hepatic venous pressure. So you can see this is an example of a patient with SVC baffle stenosis on the left, and then on the right is a 3D contrast MRI which shows dilation and prominence of the azygos vein because of stenosis of that SVC backbone. So moving on to talk about arterial switch repair in patients with transposition of great arteries, which is more commonly done and it has been done since at least the 1975. So we tend to see a lot of patients with these for cardiac MRI. So, as we all know, in arterial switch repair, the arteries are transposed, so the pulmonary artery is brought forward, and the coronary arteries are translocated as well. And the procedure is known as the Lecomte maneuver. So the goals of cardiac MRI in these patients are to assess for any branch pulmonary artery stenosis, assess the supravalvular region of the main pulmonary artery and the aorta. Supravalvular NPA stenosis is commoner. Assess for neo-aortic root dilation, a hemodynamic assessment of neopulmonary and neo-aortic regurgitation, and then evaluate the coronary arteries for stenosis since they're translocated to a different position, and then volume and function assessment. So this is a patient with Lecomte maneuver, and this is the coronal plane. You can see both branch pulmonary arteries on either side of the aorta in cross-section here. The axial plane, again, is very helpful in these patients, and here we can appreciate the extent of the Lecomte maneuver. So the branch pulmonary arteries are seen anterior to the aorta, and you can see drapes around the aorta on either side. So the left pulmonary artery is on the left side, and the right pulmonary artery on the right side. The branch pulmonary arteries are prone to stretching because of the way they're brought forward anterior to the aorta. And so any stenosis can result in these branch pulmonary arteries, and it becomes evident from this view. You can also appreciate for any neo-aortic root enlargement or supravalvular pulmonary stenosis from this view. So this was one of our patients that had developed some stenosis of the left pulmonary artery from stretching, and you can see here from the right that the 3D contrast MRI can be useful and helpful in delineating those areas of stenosis. So I just thought I'll talk briefly about RV2PA condyles, and we'll look at this example for that, which can be assessed well by cardiac MRI as well. Usually the sagittal oblique plane is useful for these patients, as a lot of the condyles are very anterior and immediately beneath the sternum. And so here you can appreciate, so the C is where the condyle essentially is and leads from the right ventricle to the pulmonary artery. And you can see stenosis in both the proximal and the distal portions of the condyle. The axial plane is also helpful in these patients for assessing relationship of condyle to sternum for surgical purposes. So next we'll move on to talk about coarctation of aorta. So in adults and adolescents, it is usually an isolated finding with late presentation. And indications for surgical repair in these patients are with coarctation gradient greater than or equal to 20 millimeters of mercury, If the gradient is less than 20 millimeters of mercury with significant anatomic coarctation and collateralization, these patients can also meet criteria for surgical repair. And then if the patient has developed systemic hypertension. There are different types of repair that can be done. Most commonly, the subclavian flap arterioplasty is used to be done, which used to be done, as in option B on the bottom right. Other options are, starting from the top A, B, and C, so end-to-end anastomosis, patch angioplasty, and interposition grafts can also be done in these patients. So the goals of cardiac MRI in coarctation are, so essentially it is a gold standard for definitive diagnosis of arch anomalies. It provides us with a large field of view. There's no exposure to ionizing radiation, and longitudinal imaging can be performed over time to compare findings. Functional and hemodynamic assessment can be done, and then surveillance of aneurysm. So in patients with that have undergone balloon angioplasty by cardiac cath or surgical repair, they can develop aneurysms at the site of repair or above or below the site of repair, and these can be followed over time using cardiac MRI accurately. And then coarctation of aorta that have had stent placement can also be assessed by black blood imaging. The goals of scanning a patient with coarctation of aorta preoperatively are, so it gives an anatomic description of the coarctation, so discrete versus diffuse, aortic arch anatomy, so head and neck vessel branching pattern, hemodynamic assessment, quantification of collateral aortic flow, associated cardiac abnormalities, including left obstructive heart lesions, surveillance for progression of unrepaired coarctation, and screening for cerebral berry aneurysms only if symptoms develop. So this is optional. And then postoperatively can be used for surveillance of progression of repaired coarctation and then surveillance for aneurysm development. So if there are stents in the area of coarctation, black blood imaging stacks can be very helpful in the sagittal plane to assess the aorta, like you can see. In these three patients, the area of coarctation is defined very well, and we'll see an example right after this where, so this is a patient that has a stent in the area of coarctation, and these are all four sequences in this image are in the same patient, and you can see how useful the black blood imaging is on the extreme left, which defines and delineates that area, and where you can see at least that there is no significant residual coarctation. So this is an example of a patient by MRA of late presentation of coarctation with collateral formation. And collateral flow can be quantified by obtaining flow in two different regions. So proximal flow, which is your red line, and then the distal flow, which is the blue line, and you can subtract proximal flow from distal flow to obtain your collateral flow volume. And in-plane flow can also be obtained, so flow parallel to the blood flow in the area of coarctation can also help estimate the degree of obstruction. So I'll just briefly talk about just a few aortic arch anomalies to give us an idea of how useful cardiac MRI is in these patients. So imaging can be done without contrast. Imaging with contrast is also safe in these patients. A quick protocol can be done. So black blood imaging for 5 minutes, limited cine imaging in the sagittal plane, which is very useful in these patients for 5 minutes. Function, volumes, and mass for another 10 minutes, contrast for 3D reconstruction for 5 minutes, and then always add time for planning and preparation, which will be another 10 minutes. So this is a patient of ours that I wanted to show. This is an 18-year-old patient with Marfan syndrome that we were obtaining echoes on until that age, and you can see that the aortic root is dilated, so we were pretty much following that. However, I decided to start surveillance with cardiac MRI, and I found an aneurysmal dilation in the proximal descending aorta, showing the usefulness of advanced cardiac imaging in these patients. And this was never seen by our limited echo windows previously. And then demonstrating other aortic arch anomalies. Here you can see a left aortic arch descending on the left side, and then with an aberrant right subclavian artery, which is the most common arch anomaly. It's not a true vascular ring. Patients are usually asymptomatic, and we may see this incidentally when scanning for other defects. And this is a 3D contrast MRI of a patient with right aortic arch with aberrant left subclavian artery. And these patients can be symptomatic, and this can be a vascular ring. So pulmonary venous anomalies can also be well seen by cardiac MRI as well, especially partial anomalous pulmonary veins, like in this case where you see the left pulmonary veins where the white arrow is joining the innominate vein. And then 4D flow is also now upcoming, mostly at the research stage, but also being used in a lot of institutions and can demonstrate anomalous venous connections with this sequence. So on the top, you can see in panel A where the red arrow is, there is a partial anomalous right pulmonary vein. Panel B also shows a partial anomalous right pulmonary vein, again where the arrow is. And then panel C shows a sinus venosus ASD and a partial anomalous pulmonary vein, where you see the red arrow. So MRI is a great tool to look for sinus venosus ASD as well in unexplained right ventricular dilation. And then this is an example of an unroofed coronary sinus, essentially resulting in an atrial left to right shunt. And this is a patient with another systemic venous anomaly, so interrupted IVC with azygous continuation. And you can see that very well in the sagittal view. So this can often be confused. Something to remember is with the aortic arch, especially if very prominent, like in this case. So I'll end my talk by talking about single ventricle physiology. So cardiac MRI can be done in patients with palliative procedures for single ventricle physiology, including the Glenn, after the Glenn procedure, and then after Fontan. So in the three types of Fontan, lateral tunnel, atriopulmonary, and extracardiac Fontans. The goals of cardiac MRI in patients with single ventricle physiology include, so I'll talk about the Glenn first, which precedes the Fontan. So you can assess proximal insertion of the Glenn into the branch pulmonary artery. So you can look for stenosis. You can assess for pulmonary artery dilation, and then collateral formation. In patients with Fontan, we can look at the conduit and assess for stenosis to the systemic venous pathway, so it connects to the SVC on top and the IVC at the bottom, and then ventricular function, assess for AV valve regurgitation of the single ventricle, pulmonary venous compression, and then assess for any thrombus in the Fontan pathway. So here, this is a patient of ours where you can see this was an extracardiac Fontan baffle, and then this is the baffle right here. It is in the oblique sagittal plane, and you can see, with the SVC and IVC connection, so a good view to look for any levels of stenosis in the conduit or dilation. So these are examples. On the left, you see on the top left panel is a classic atriopulmonary Fontan, and on the top right is an extracardiac Fontan conduit. So both are seen by coronal plane imaging. So coronal plane imaging is very useful to look at the whole Fontan conduit. This is an example on the left of a dilated IVC portion of the condyle, and in the same patient, there is a large IVC with dilation of the hepatic veins as a result of dilation of that portion of the condyle. IVC condyle stenosis can also be seen, like I mentioned earlier. And in this patient, you can see stenosis at the point of anastomosis, and there is post-stenotic dilation of the main pulmonary artery. So I'll end my talk by talking about, we talked about all the useful applications of cardiac MRI in patients with adult congenital heart disease, but there's also limited utility of the cardiac MRI in these patients. So valve stenosis and detailed valve morphology is difficult to obtain by cardiac MRI. Valve vegetations cannot be seen very well by cardiac MRI. We are limited as to assessing for coronary artery stenosis. So CT scans are more superior in those cases. Distal pulmonary arteries can be seen, but probably, if you're looking to assess further, a CT scan is probably more useful in those cases. Small aortic pulmonary collaterals cannot be very well seen. And then if there's lung parenchymal disease, we're limited by cardiac MRI, any bronchial abnormalities. And then artifact is caused from metallic devices, so stents, occluders, coils, may be in your field of view and obscure the anatomy of interest. And with that, I'll end my talk. Thank you very much. And I'm happy to take any questions.
Thank you, Professor Chowdhury. You're welcome in our meeting. Hope you can enjoy some of our presentation. I am very excited about your presentation and difficult topics that you presented here. And as you're an expert in cardiac MRI, when you, I have one simple question. When you propose it to send the patient with adult congenital heart disease for the cardiac MRI, this is the gold standard usually. But if the echo is perfect in that of kind patient, can we use for additional information the MRI of that of kind patient?
Yes, thank you, Dr. Ristova, for inviting us to talk in this conference. I was very excited, to do this talk for all of you. So that's a great question. So, I think like you showed in your example, so definitely, there are certain parts of the heart we still perform echo in these patients, of course, to start with. And, you will still get some information. So for example, in a patient with tetralogy of Fallot, you were able to see the free pulmonary insufficiency. You can probably see the function to some extent, but cardiac MRI is definitely, great to do in these patients in addition, because just that, functional and volume assessment is just more accurate, especially of the right ventricle. As we know, because of the geometry of the right ventricle, often assessment by echo, and to see it completely, the complete structure is harder. So, definitely in those patients, we find it very useful, when we're trying to take decisions for pulmonary valve replacement, and whether they meet criteria. And also in these patients, I think visualization of the branch pulmonary arteries also becomes more difficult over time. So, I think cardiac MRI is very useful in those cases for that as well. And then what we tend to see, with cath interventions, especially because we usually try to put them forward for a transcatheter pulmonary valve placement, is that we delineate the coronary artery anatomy for them as well, which they find very useful. And then also measurements of the right ventricular outflow tract, accurately. So I think definitely, we perform echo in all these patients, but cardiac MRI is very helpful in cases like that. And then I showed an example of a patient with Marfan syndrome, which I had, and there we were following his aortic root dilation over time with echocardiography. I knew I would have to follow this with echo at regular intervals, but then starting to do, which is recommended, from adolescence onwards, to start advanced imaging. And as soon as I obtained the cardiac MRI, I was able to see that aneurysmal dilation of the proximal descending aorta, which I otherwise, was not able to see before. So yes, definitely a helpful adjunct to echo imaging.
Thank you. Thank you so much. Professor Lee, do you have any comments? Professor Ho?
Sorry. Oh, unable to start video. Anyway, I think really a wonderful talk and covered a lot of varieties of individual lesions. I know MRI is become widely available and has been used in assessing congenital heart disease more and more. I think definitely is preferred method of evaluation for extracardiac structure.
Yes.
Intracardiac structure like a valve and inside the septum, I think echo still have its advantages because we have Doppler, we have color. So it's complementary with each other, and we can use both with its advantages and to benefit patient care. Thank you.
Yes, thank you very much, Dr. Lee. I completely agree with that. Like I said earlier, definitely the two different imaging modalities are complementary to each other, and we get different, sources of information from each, which are all useful eventually to make that decision for the patient. Thank you.
Dr. Nita, there is one more question from the audience. There is very practical, I think. Do you include the aneurysmal portion of the right ventricular outflow tract in right ventricular volume in functional assessment?
Yes, so we do. If the pulmonary, and these are in patients that have had a transannular patch repair where their RVOT becomes aneurysmal. So yes, we include the RVOT in the function and volume assessment. So in patients that have had a valve sparing repair where you still see the pulmonary valve, basically a complete pulmonary valve, you'd include the RVOT below the pulmonary valve. So that's the difference in how we do the assessments.
Okay, thank you. Thank you so much.
Thank you very much.
There is not question, but you can stay until the end of the session, and today there will be perform small discussion on the end. Okay,
thank you very much. This conference has been great. Thank you for inviting us again.
Thank you. And we will continue with the role of the computer tomography in adult congenital heart disease. And my pleasure to introduce Dr. Madhavi Kadilaya. She is associated professor and expert on the computer tomography in adult congenital heart disease. She is coming from the West Virginia University again.
Good evening, everyone. Dr. Hristova, can you hear me?
Yes.
Thank you again for inviting us to this conference. Again, greetings from West Virginia. My topic, and Dr. Nita Ray Chowdhury, my colleague, did a wonderful introduction, and she made my job easy. So I'll talk about cardiac CT in adult congenital heart disease. And my disclosure is I am an adult cardiac imager, and I'm not a pediatric cardiologist. But there is a tsunami of adult congenital heart disease coming at the adult physicians as well. And this conference is particularly targeted towards that. There's an increasing burden of ACHT patients. Almost the statistics show 5% increase per year, 1 million patients in America. The average age of these patients is going up, and we're having a substantial number of people at 60s who are also now having both acquired heart disease and in addition to congenital heart disease, and we're increasingly taking care of these patients, and cardiac CT has an important role in the assessment of these patients. Now, which modality should we be using, whether it's echo, CT, MRI, TE? It really depends on the question being asked. What are the patient factors? What are the strengths and weaknesses of modalities? And what's the local expertise that is available? Fortunately, we work in a place where all modalities are available and expertise is available. So we get to choose which modality for which patient. Now, in general, the principles, the go-to modality is always transthoracic echo. As this audience knows, TE is invasive and we limit that when it is necessary. Now, CT, of course, there is radiation, and that's the reason why when we have young patients, we prefer not to go there unless it is required. Now, right-sided assessment, again, right ventricle is often difficult to assess with echo, even with the TE at times. And in this situation, the preferred modality is MRI, and CT may be valuable in select situations. Again, as we discussed earlier, accurate quantitation of chamber volumes, which is often important. MRI is your gold standard. The limitations of MRI, as we know, it can be a long exam time. If you have metal implants, there can be contraindications. Again, some patients are claustrophobic, and of course, we can do it under anesthesia, but that has its own limitations because these images are best when the patient is able to hold their breath. So, what are the advantages of CT? It is widely available, less technical expertise needed to operate a CT scanner. Again, the examination is much quicker, even in those who, especially in those who have difficulty holding breath for a long time. Claustrophobia, because it's a shorter exam. Again, if you have artifacts from devices and coils, this may be preferable. If you have a device or a defibrillator that one cannot do an MRI, although we are having a lot more MRI conditional pacemakers and defibrillators now. These are patients where you might want to consider a CT. The CT also has much higher spatial resolution, voxel resolution that allows us to do very detailed 3D analysis. Again, this is, you can get the images first and then spend time post-processing and get detailed information. So that makes it a lot more easier. Also, small structures like coronary arteries are better visualized on CT. Cine imaging is feasible. Again, it requires a lot more radiation, so we generally do not prefer to do it unless it is required. We typically try to do single phase imaging in order to save radiation costs. Now, the biggest limitations are, the risk of contrast-induced nephropathy is extremely low, but in patients with renal dysfunction, this is a consideration. Again, we cannot assess regurgitation and shunt fractions on CT. And radiation is, again, something that we should always be aware of if we can avoid it. Now, one thing it's important to understand is for CT labs, it's a little bit more complex involving the congenital heart patients than the adult cardiology patients because we have, as you saw, very complex pathology. There are established protocols, and the lab should have some expertise in knowing which protocol to use when. For coronaries versus if you're looking at both left and right ventricle, you might need a triphasic protocol. If you're looking at Fontan physiology, now that might require more expertise where you need split bolus protocol, one from the SVC and one from the IVC contrast injection. And if you're looking at venous phase, it's a longer injection, and sometimes you need delayed phase acquisition. So to know how to do this requires a little bit of expertise. Now let's look at some applications. coronary arteries. And when do we think about coronary evaluation in ACHD patients? And one is when it may be a primary coronary anomaly by itself. The other situation is in the situation of a repaired congenital heart disease, and we need to look at what effect the repair may have on the coronary arteries. This is an example of a native anomalous coronary disease. Again, here you have your right coronary artery going, and this is an anomalous left anterior descending artery that is originating from the right coronary artery, and it has a subpulmonic course, which and goes into the interventricular groove. The left circumflex originates, as it would, from the left coronary sinus. So this is an example of an anomalous LAD with a subpulmonic course. Now this example is, you have here your left coronary sinus and your left LAD and the circumflex, but the right coronary artery is also originating from the left sinus, and it has a retroaortic course and then goes into the right-sided AV groove. This is an example of a dual LAD. Part of the LAD territory is being supplied by an anomalous LAD, which originates again from the right coronary artery, traverses through the right ventricle, and enters the interventricular septal portion. And the part of the LAD, the mid and distal LAD in this case, is originating from the left side, as it would, and including the first septal perforator, and it supplies the distal portion in this case. Now, the more malignant variant, which we all know, is the interarterial course of the right coronary artery. Again, this is where you see the interarterial course, whether left or right. Here in this situation, the right coronary artery is coming from the left sinus, and it has a narrow split-like orifice, which you can see in very fine detail on CT imaging. This kind of detail is difficult with any other technique. And it also, the proximal portion traverses in the intramural portion of the aorta. So this is clearly being compressed between the pulmonary artery and aorta, and this is the more malignant variant that would require treatment. And the same thing, you can see it in a multiplanar reformat where it's narrowed and thin and compressed between the pulmonary artery and the aorta here. And the 3D reconstructions would show you from the left sinus, you see the right coronary artery coming this direction. Now, the relevance would be, what are the relevance of these different variants? Now, if you have a retroaortic, it's usually benign, but you would want to know if you're planning any kind of aortic root interventions, you would want to know where the vessels are. A prepulmonic one is where the coronary artery, the LAD, instead of going behind the pulmonary artery, it's actually going around it. And this would have an implication when you're planning for surgical operation, as it lies right under the sternum. And this can sometimes be seen in patients with tetralogy of Fallot. Now, the intramural course, where you see the split-like orifice, is the most malignant variant and often requires unroofing or marsupialization surgical procedures. Another variant is the Al-Kappa, where the left main coronary artery is originating from the pulmonary artery. So in this situation, the physiology is the flow is reversed. There are significant right-sided collaterals, and the flow is going into the pulmonary artery, as the pulmonary artery is the low pressure chamber. This results in a steal phenomena, coronary steal phenomena, with the left ventricle not getting the blood supply it should, resulting in long-term LV dysfunction and heart failure. So when these kind of cases are imaged, again, important also is to note the position of where the left coronary artery is connecting. Now, if the left coronary artery is connecting on the left side like this, it may be difficult to translocate it into aorta. However, if it is located more closer to the right side of the pulmonary trunk, it has enough, usually it has enough stretch to be translocated. So the position and location matters much for pre-surgical planning. Now let's look at some shunts. Now, the most common cardiac shunt that we see in adult hearts is an atrial septal defect. These, if they're small enough, they can go undiagnosed until patient presents in the 30s or 40s. Now, again, typically we don't do CT to evaluate a shunt. Usually echo or TE would be more than enough. But if it is present, again, you see a defect in the septum, again, right ventricular dilatation. That often goes with the ASD. A primum ASD, again, you would see a defect more closer to the AV group, atrioventricular valve portion. Again, this is another example right here, and you see a little bit of contrast flow going towards the right. In this case, there may also be a coexisting ventricular septal defect along with the ASD. In sinus venosus ASD, the defect is more closer to where the vena cava would be, either with the superior vena cava or the inferior vena cava. Again, you see it more towards the roof of the left atrial wall. As you know, sinus venosus ASD is very commonly associated with anomalous pulmonary venous return, and it's always important to evaluate where the pulmonary venous veins are being attached to. And in this example, you can see the right upper pulmonary vein and the middle pulmonary vein actually connecting to the superior vena cava instead of the left atrium, resulting in a significant left to right shunt. Again, nice detail of an unroofed coronary sinus defect. You see the coronary sinus here, left atrium and right atrium. And you see that there is contrast that leaks out here. And this is a unroofed coronary sinus. Again, it has a very high association with persistent left superior vena cava. Now, ventricular septal defects also, again, can be seen. This is an example of a membranous VSD. Usually the membranous VSDs, they are often partially closed with part of the anterior tricuspid leaflet and can have an aneurysmal formation. The detail is, and the flow and detail is much better appreciated on echo imaging, but you can see some detail here. Muscular VSDs, you would be seeing them here. Again, this is not the first modality that you would do to evaluate septal defects, but you can see in select situations. Now, conotruncal abnormalities that Dr. Neeta Ray-Chaudhuri has already assessed in detail. I won't go too much into them, but we're talking about outflow tract abnormalities, which include tetralogy of Fallot, transposition, double outlet right or left ventricle, interrupted aortic arch, and aortopulmonary septal defect. Now, when we talk about transposition, we are talking about ventriculo-arterial discordance, meaning the left ventricle is actually giving rise to pulmonary artery, and the right ventricle is giving rise to the aorta. And how do you identify the arteries? Is by their branch vessels. Whichever is giving out the carotids and subclavians, that would be your aorta, and the pulmonary one would be the pulmonary artery. And one important imaging feature is understanding the relationship between the aorta and pulmonary artery in your axial slices. Aorta is normally posterior and right of pulmonary artery. This is a normal situation, reversed in dextrocardia. In detransposition, the aorta is towards the right of the anterior and right of the pulmonary artery, and in L transposition, it's towards the left and anterior of the pulmonary artery, and we'll review this again. Again, this is the detransposition is the more common transposition. Again, you have ventriculo-arterial discordance, meaning the wrong ventricle, the wrong artery is connected to the ventricle. But there is atrioventricular concordance, meaning the left atrium is connected to the left ventricle, which is going to the pulmonary artery. Now, as we already reviewed this, the repairs include atrial switch or arterial switch, in some cases complex repair. This is an example of a detransposition after repair, which is this patient had Mustard procedure. Meaning first you can see that the aorta is towards the right of the pulmonary artery, and it is also anterior. So that's a clue. Again, here you can see that the Mustard procedure, meaning atrial switch, has already taken place. And the pulmonary venous return has been now connected to the right ventricle and the tricuspid valve, which is now functioning as a systemic ventricle. And here the SVC and IVC are reconnected to the pulmonic ventricle. And these images can be sliced and diced in whatever fashion in three-dimensional imaging. And that's I think, the biggest advantage of once you get these images. The complications of, it's again, CT is excellent for evaluating the complications of atrial switch, particularly the baffled stenosis. Again, leak is not so well visualized, but stenosis, dilatation of the right ventricle. We cannot really look at tricuspid regurgitation on CT, but a lot of these patients will have bradyarrhythmias requiring pacemaker implantation, and the CT assessment can be very helpful before placing the pacemaker to establish this venous connections. Now, post-arterial switch, which is the more commonly done procedure, the Rastelli procedure, again, post the procedure, CT can be very helpful, especially because there are altered stretch mechanics of the aorta and the pulmonary artery. You can, to evaluate for coronary ostial stenosis, the neopulmonary trunk and branch stenosis, just like we would do in MRI. Again, more detailed information, root dilatation. Again, regurgitation is not something we could see it on CT. L transposition, here, it's a congenitally corrected transposition. Although there is ventricular arterial discordance, there is also atrioventricular discordance. Therefore, it congenitally corrects itself. The flow from the venous, systemic venous flow goes to the aorta and the vice versa. But the wrong ventricle is doing the job. So therefore you'll see the morphological right ventricle or the systemic ventricle that hypertrophied. Again, the clue is the aorta is anterior and left of the pulmonary artery. This is a case from our lab where you can see it both on axial images. What the atrial switch has congenitally already happened. So you also see here the nicely dilated right ventricle, hypertrophied ventricle. But these patients are often picked up late because they don't present until late with heart failure, with right-sided heart failure. And here's a nice 3D reconstruction where the right ventricle or the anterior, the morphological right ventricle and the anterior ventricle is giving rise to the aorta, and the posterior ventricle is giving rise to the pulmonary artery, the reverse. Now, one way to, sometimes it gets confusing to know which ventricle is which in this transposition. Again, what we need to remember is the atrium with the left atrial appendage is the one that is connecting to the systemic ventricle. And you also see that there is absence of fibrous continuity between the AV valve, in this case tricuspid valve, and the aortic valve. There is apical displacement of the AV valve in the systemic ventricle. Again, moderator band. You see that you see that in the systemic ventricle, and there are prominent trabeculations. I'll go over a case of tetralogy of Fallot in which we use CT to do pre-procedural planning. We already know what components of tetralogy of Fallot are, and the repairs, generally when we see them in the adult world, we see them post-repair, we don't see them de novo tetralogy of Fallot. Usually they would have had stage 2, meaning ligation of the BT shunt would have happened. And these are patients who have undergone repair of the a repair or relief of the right ventricular outflow tract obstruction and closure of VSD. So the complications that we often see are the progressive pulmonic regurgitation with right heart dysfunction. Is there a branch pulmonary artery stenosis, RVOT aneurysms, recurrent VSDs, and these MAPCAs are not usually seen if they're treated early. In this case that I'll show you, is a 38-year-old woman with dyspnea on exertion. She has tetralogy of Fallot repaired at 18 months of age, subsequently developed pulmonic regurgitation, and eventually and underwent a surgical pulmonic valve replacement with an Edwards Sapien 25 millimeter valve when she was 28 years old. So 10 years later, now she presents with dyspnea on exertion. The echocardiogram shows that she has significant gradient across the bioprosthetic valve with a peak gradient of 56 millimeters and a mean of 36 millimeter. She's symptomatic, and it's bioprosthetic pulmonic stenosis is diagnosed as per guideline recommendation. Coronary angiography by any advanced modality at least once in adulthood is recommended for surgically manipulated coronaries before RVOT intervention. This person was being considered for valve-in-valve transcatheter therapies. So CT was done, and in this case, a cine CT was done. Again, this is more radiation than single-phase imaging. And you see the RV function, and this can be quantitated. And you also see that there's significant calcification in the valve. Again, it's not so great to planimeter a calcified valve, but you see significant calcification. And you also evaluate where the coronary arteries are. Again, it's less relevant for a valve-in-valve because it's easier to implant it, but for a native situation, the relationship with the RV outflow tract area would be much more important. In this case, the coronaries were far away from the area of intervention, and this case was deemed a good candidate for valve-in-valve. Again, this is an example of a nicely depicted RV outflow tract aneurysm. Again, for a valve-in-valve, it just goes into the already existing prosthetic rings, and it was deemed after looking at all the angles that this patient would be a good candidate for transcatheter valve-in-valve. And it was successfully done. I don't know if it'll play. Okay. So this is the transcatheter valve that was placed with the relief of obstruction and a relief in patient's symptoms. The gradient went down to 15 millimeter in this patient. So we see that pre-procedural planning for CT can be very helpful, particularly for a native valve, evaluation of the landing zone, the size of the RV outflow tract, whether it's distensible or not, and the shape of the valve, the outflow tract. All these factors are taken into account by the interventionalist, the surrounding coronary anatomy. And again, it's important to remember that metal stent frames are better visualized by CT. Oftentimes you get susceptibility artifact with MR imaging. Now, another case that I like, again, we discussed that for right heart evaluation, the advanced imaging, whether it's CT or MR, can be helpful. And this is an interesting case that I'd like to share. This is actually a 66-year-old woman who presented with chest pain and was refusing to undergo a transthoracic echo because she would get a lot of pain once the probe was placed on her chest. She did have history of mild pulmonic stenosis as a child, and she was lost to follow-up. Because she wasn't allowing anyone to do an echo, CT was done. Again, here on chest X-ray, you see a hilar prominence. And this was one remarkable CT angiogram. And it was, because she was 66, the referring physician was more concerned about coronary artery disease and wasn't done with a thoracic protocol. We did a coronary artery protocol and were surprised looking at that large, gigantic pulmonary artery. I'll let it roll one more time so you can see it. It's one of the largest pulmonary arteries that we saw. And if you look at the multiplanar reformats, and we tried to do valve planimetry, this sort of images is very unusual. You don't really see a contrast difference between the outflow tract and pulmonary artery generally, but the fact that you do see that there is already different signal intensity in the pulmonary artery and RV outflow tract suggests that there was significant stenosis. This sort of images is not very common in CT imaging. But again, because there's non-contrast blood in the outflow tract and the leaflet tissue, this is very difficult to know where to planimeter and how to planimeter in this situation. So this patient actually underwent MRI eventually. And one thing that we saw was that depending on where the images were acquired, the valve area would change. Now, this is a lower acquisition, and this is an acquisition at the tip of the leaflets. Now, one can apply the same principle to echocardiography, and if you don't really get the right plane with 3D imaging, you can miss the degree of stenosis. And this case nicely illustrates the fact that 3D imaging is often necessary to accurately determine the valve planimetry. In this situation, the planimetry was done on both cine imaging and phase contrast imaging, which was both, there's some variation, but it was considered significant enough. Again, MR angiogram can be done just like CT. This requires contrast, and because we didn't get a full CT angiogram, we did do an MR angiogram, and you get very good images and very helpful for surgical planning as well. And this is intraoperative imaging. And now that we have nice CT and MR imaging, we tried to do 3D imaging. As you know, pulmonic valve is very far away from the echo probe, and it's challenging and almost very difficult to get good 3D images, but this is our best attempt. And we tried to do planimetry, which I don't think anyone can accurately, reliably do what the images are, or what the area is. On operation, the patient did have a congenitally abnormal tricuspid valve with fusion of all leaflets, and it was doming of leaflets with a small orifice was confirmed, and there was moderate calcification. I want to share one last case, which is an interesting phenomena, is an atrial mass on CT. Now, this is an example of an atrial mass that was that I was asked to do a TE on a patient because the surgeons were informed about this large mass in the left atrium, and the patient was being scheduled for a surgery. We did not know what the mass was, and the TE was, we were asked to do a TE. So this is the TE, and it was done the following day, and I could not find the mass. So in one day, a large mass disappeared. We tried to look for it, couldn't find it. And I know it's not interactive, but it was very unusual that the entire mass would go disappearing. But there is a clue as to why we don't see that mass in the echocardiogram. And I'll point out that, there's this very aneurysmal interatrial septum. There's a prominent eustachian valve. The right atrium is small. And you see a flow coming from the SVC over here. I'll explain why this is relevant. We did a shunt study, and if you look at the shunt study, the shunt is the agitated bubbles are being injected from the upper extremities, and you see that the bubbles are here, but not going here. And this is flow in the SVC. This is the flow in the IVC. And perhaps you might get an idea as to what is happening here. So if you further imaging, you'll see that there's separation of flow of IVC and SVC from the prominent eustachian valve. Now, this is something that happens in utero, and that is physiologic because you want the SVC flow to go. The IVC flow is the oxygenated blood, and IVC flow is shunted across the patent foramen ovale into the left side circulation. So it goes to the aorta in the brain, and this is a natural mechanism of giving the highest oxygenated blood to the brain. And the mixing happens at the level of PDA. Now, in some situations like this patient, there's a persistent fetal flow pattern. So what in fact happened was because there's no mixing within the atrium, the IVC flow, which is non-contrast blood, was being directed towards this interatrial septum and gave the appearance of a pseudomass and wasn't a real mass. And so this is where I think the understanding of what flow happens, where the anatomical abnormalities can play a role is helpful in understanding these imaging phenomena. And in fact, this is going to be published soon in Circulation Imaging, and you stay tuned for the publication. We have a few more cases with this phenomena being presented in this paper. And I won't go into the details of thoracic aortic abnormalities. Dr. Nita already went through over them, but CT is excellent for all of these imaging. Again, this is an example of a vascular sling. Again, pulmonary artery abnormality. Any vascular structure, CT is excellent. And this is an example of a pulmonary vascular ring that is going around the trachea. Scimitar syndrome, again, this is an example of a partial anomalous pulmonary vein returning into the inferior vena cava. It creates the scimitar appearance, well-known condition, and also associated with the hypoplastic right lung. Again, venous, arterial, whether it's aortic or pulmonary artery, CT is excellent at looking at these things. The systemic venous abnormalities like persistent left SVC or interrupted IVC, these are again very well characterized. Usually we don't do anything about them, but you do want to know that they exist. It's important to be aware of them, especially when you're planning for central venous access, cardiopulmonary bypass, or device implantation. In summary, cardiac CT can be helpful in initial diagnosis as well as follow-up imaging to assess post-repair complications. We saw how it can be helpful for pre-surgical planning, excellent tool to evaluate cardiac, extracardiac, and vascular abnormalities, particularly when echo and cardiac MRI are not possible, and it is the default modality to assess small structures like coronary arteries. And I want to point you to, if anyone's interested, to this excellent reference published in 2019, which goes into more detail into the protocols as well as a more complex pathology like single ventricular physiology. And thank you from our program, and this is our team, the adult cardiologist, pediatric cardiologist, the radiologist, and we have 2 cardiac imaging fellows. And I particularly want to also acknowledge Dr. Zeb, who shared many of his cases for this presentation. Thank you.
Thank you, Professor Mahdavi. It was very pleasant for us to have it in our program, and hope that we will continue our collaboration in the future. I think we can continue with our communication also, and did you be a little bit more details regarding to the Fontan circulation? How is possible to going to be with the CT more helpful for the echographer to be for, especially for the hemodynamics?
So again, I think Dr. Nita Chowdhury is probably better qualified to answer that question. She deals with Fontans much more than I do. For my, like as we saw, an anatomical detail, it does takes a little bit of complexity in getting the right kind of CT. In some situations, you actually have to inject both extremities at the same time. It's called the split bolus protocol, where you inject both the lower and upper extremities. And depending on if there is a Fontan obstruction, you have to use the protocol to, do a longer scan, or even do a second phase scanning. And oftentimes it actually requires either the pediatric imager, and this is where I think a collaboration between I'm learning really from my colleagues who are much more experienced in dealing with this complex connections, and with our radiologists. So I think it's a process that we're all learning to see them as we are seeing more of these adult patients. But this is exactly a situation where a collaborative approach and team approach would be helpful to both communicate to the person who's doing the scanning protocols, as well as communicating what exactly we're looking for, what is the clinical concern. I don't know if Dr. Chowdhury wants to add anything here.
I heard just part of the question. If you could please repeat the question, that would be great.
Oh, the question was about more detail in evaluating Fontan circulations and Fontan physiology with CT imaging.
Yeah, I think so. So we find MR imaging to be more useful for Fontan imaging in general in patients with Fontan circulation, and that is because we can assess for collateral burden, and we can, it is pretty much like a one-stop shop. You can look for thrombus, and you can look at the conduit in details. The CT is useful in some of the patients. We do them, but I think more rarely. And it would basically be in those patients, that have a pacemaker and, that are not pretty much suitable for a cardiac MRI assessment. So in those patients, we basically, it would give us an idea, to look at the conduit, look for any stenosis, look for any thrombus. So in those cases, CT would be useful, and we're also able to assess ventricular function and volumes with CT in those cases. But we pretty much always divert to MRI, cardiac MRI, when we can with these patients, just because you still get an overall more useful information from that if you can help it. So.
Professor Lee, do you have any question or comments?
Thanks for the interesting talk. I've just been impressed by your cases of this mass in the right atrium. You think it's the SVC fetal physiology, yeah? Interesting. I just wondered how sensitive or specific CT in tissue identification, like how easy you can differentiate between tissue, between vascular mass and non-vascular mass.
So again, a lot of it depends on the timing of the contrast. Usually you do see increased signal, or if you see vascularity, you can see you can see vascularity on CT masses. Again, with MRI, what I've found in my practice is that with perfusion imaging can help significantly with the mass evaluation, but it depends on the size of the mass. I think if it's a small mass, it can be difficult to look at the perfusion because what we call as partial volume effects. It's a small mass, and each of these slices are 8 millimeter thick, and MRI can be difficult. In CT seems to be, as long as you time the arterial phase and it's not a delayed scan, you should be able to look at the vascularity of a tumor quite well. Sometimes it actually takes putting things together. You have to look at the echo images and the CT and MR images to also really establish the accurate diagnosis. And that's where I think the multimodality approaches becomes very important.
I know in the past, we have sent patients for surgery based on the mass, find it only by echo, and surgeon opens, there is nothing in it. So it's just emphasizing how important this multimodality imaging. You see your TOE on this case is very useful, isn't it?
It is.
And another thing I find in patients with this kind of huge eustachian valve, we can often miss the PFO. When there's a hole is located at this area, if you didn't inject from right place, you will miss the shunt.
Absolutely.
So that's another thing we have to learn.
And this is exactly the point of the paper. It should be published coming up soon in the next week. And we are trying to emphasize that because the stool flow pattern exists and we don't recognize it as as often as it is.
Yeah. You have to inject from the leg in order to get the area occupied, isn't it? Thank you. Wonderful talk.
Thank you.
Thank you once again. And actually, every year in our SOFIA Echo Days, we given the opportunity to teaching for the fetal echocardiography. And this year, we will continue with our tradition, and I would like to invite the next speaker. She's a perinatal obstetrician and very perfect expert in congenital heart disease and fetal echocardiography. It's my pleasure to introduce Dr. Marina Mihova.
Hello to everybody who has managed to stay with us until the very end of such a long, exhausting 2 days of cardiology. Now I shall start sharing my screen. I hope that everything is visible.
Yes. Yes.
Okay, let's get started. First, Professor
No, yeah, it's good. Thank you.
Okay. First, Professor Christova has already introduced me, but my name is Marina Michova and I'm an obstetrician. I work in the field of prenatal medicine since for the last 12 years, and for this period I have worked in collaboration side by side by an expert pediatric cardiologist and an excellent human genetic team, and I believe that the best care for pregnant patients carrying babies with congenital heart disease can be made only in collaboration. So I would like to say thank you to my team as well. So what we do is a rather bit different from what the cardiologists do, but what we do is complete heart examination during the period between 18 and 23 weeks. As you already know, the examination of the heart doesn't begin with the heart. First we take a glance at the abdominal situs. So like this picture here, we can ensure that stomach lies on the left, aorta lies on the left, inferior vena cava is on the right side, and umbilical vein courses to the right side, as it should be. Next, we ensure that the stomach and the heart lie on the same side. Next, we do the 4-chamber view of the heart, and optimally we take at least two pictures of two 4-chamber views, one for the lateral 4-chamber view to view the septum, and the second one apical 4-chamber view to view the to have a better view of the AV valves. Afterwards, we move a little bit upwards in the fetal thorax, and we can imagine the left outflow tract. Then we move upwards once again, and we represent, this image here represents the three-vessel view. And optimally, when we demonstrate the three-vessel view, we try very hard to demonstrate the bifurcation of the main pulmonary artery. And on the sagittal, from the sagittal view of the chest, we demonstrate the sagittal aortic arch because this is an important view to exclude coarctation. In every case which enters our examination room, we perform cardiac Doppler. We do believe that the cardiac Doppler is very important part of the heart investigation. We never leave the patient without performing a Doppler. And on the color Doppler application, we always demonstrate the 4-chamber view with separate flow through the both ventricles. We demonstrate the left outflow tract. We demonstrate the three-vessel and trachea view. We try very hard to imagine to make an image of the pulmonary veins, and on the three-vessel and trachea view, we always reduce the PRF, like here, to demonstrate that aberrant right subclavian arteries is either present or absent. And we perform almost the same images, of course, not quite the same quality at the first trimester scan between 12 and 14 weeks, or at least we try to. And why is the importance of prenatal diagnosis of congenital heart disease so important? First, they are the most common inborn errors in the human life. According to a large study made in Baltimore, between 19 to 75 per 1,000 live births are affected by congenital heart disease. Probably these numbers are a little bit exaggerated because they include a lot of cases of bicuspid aortic valve, patent ductus arteriosus, which is, as you know, more often in babies born prematurely. So probably these numbers are a little bit exaggerated. I have read a large study in Germany which decided prevalence is between 5 to 8 per 1,000, but nevertheless, the numbers are quite high. And this high prevalence is also associated with significant morbidity and mortality in neonatal life and childhood. And except infectious diseases, congenital heart diseases are the second most common cause of death during the early childhood. And for many conditions, as I will demonstrate a little bit later, the prenatal diagnosis of congenital heart disease does change the prognosis of the situation. What is the role exactly, what is the exact role of fetal echocardiography? It could be summarized as follows. First, diagnosis and prognosis of fetuses with congenital heart diseases should be demonstrated. This means that we have to answer the question, what anomaly is against us, and what is the prognosis of this anomaly, because from legal point of view in our country, every woman carrying a child with major or critical heart disease has the legal right to for pregnancy termination. So we have to give a very good counseling to the patients in order to make certain decision about the fate of this pregnancy. It is very important to recognize potential neonatal emergencies, and in cases where there is a high probability of needed intubation, prostaglandin treatment, immediate cardiac surgeries. Probably these cases are better taken care of in a tertiary center, because intrauterine transportation is the best for the babies, especially the babies with congenital heart disease. It is very important to make a diagnosis and search for associated conditions, for example, associated structural anomalies and genetic diseases, because this happens quite often in utero. And this diagnosis nowadays could be made even earlier. I mean, I shall demonstrate a case with hypoplastic left heart, which is suspected and confirmed during the 12 week scan. Exactly, the woman was 12 weeks plus 6 days. Here is the same case with applied color. We see only one channel filling the heart cavity, only one valve opening and closing. And on the next slide, the two major findings in hypoplastic heart syndrome are confirmed. I mean, the one ventricular inflow tract and retrograde filling of the aorta on the V sign. Here are several cases from our practice. First, this is a tetralogy of Fallot. Here opening and closing of the aortic valve, which overrides the ventricular septum, is demonstrated. And here the ventricular septal defect, along with the pulmonary stenosis with rather good branch, with rather good pattern of branching. Here, our cardiologist did the follow-up of the woman, and now the baby is alive and well at home, operated, of course, but this was considered as a good prognosis case, and it was exactly at the end of the day. And here is unfortunately another case in which, again, tetralogy of Fallot was diagnosed at 17 weeks. Here we can see the overriding of the aorta and smallish but patent main pulmonary artery. During the follow-up, unfortunately, this case ended as a pulmonary atresia VSD because the pulmonary artery stopped to be patent and started to be perfused in retrograde fashion. So at this, I mean that sometimes the situations varies from case to case. In one case, we have a good prognosis fellow. In other cases, we have bad prognosis follow of tetralogy of follow. So the follow-up is extremely important in order to counsel the patients the correct way, because the cardiac anomalies, they are usually a spectrum of disease, not a single disease. For several diagnoses represent potential of neonatal emergency, and the organization of the patient care is better if it's known before the delivery. Here we have a very recent case. It happened about 2 years ago of total anomalous pulmonary venous return. As you see here, the pulmonary veins are aiming towards the left atrium, but they are not reaching it. Here we can see that the vessels, that the veins again aim at the left atrium, but they actually enter a collector behind the heart. And here with the spectral analysis, we see that there is the pattern of blood flow with spectral Doppler is not the normal one, which we see in pulmonary veins, because this is a case of infradiaphragmatic total anomalous pulmonary venous return. And here is the same case, but in video. You see that the both veins again are entering the collector behind the heart, although at the first glance it appears as though they are reaching the left atrium. They do not. Another case in which prenatal diagnosis changes the prognosis are the cases in which total transposition of the great vessels. As you see, the four-chamber view looks totally normal in this case, but when you turn toward the left, toward examination of the outflow tracts, you see that the vessels come in parallel fashion, both with color and B mode. And when we look at this case in live in video, we see that the vessel coming from the right ventricle is actually the aorta, while the vessel coming from the left ventricle branches soon after its offspring from the ventricle. So in such cases, it is very important to make a diagnosis prenatally, because such children, they do need special care and expert center. During the technical advances, we are actually able to diagnose many of the cardiac diseases even in the first trimester. This is a case of a 13 weeks baby, which also had transposition of the great vessels, and it is quite demonstrative here. Unfortunately, when
Dr. Michova, do you hear me? there is some technical problems with the net connection. Could we resolve the problem? Ало. Добре. We will continue in a short time with Dr. Michova. Maybe we can make some very short comments about the presentation here, because actually the fatal risk for the congenital heart disease is very high when we have some of the common lesion that could be found in the early stage of during the pregnancy. Risk of the transmission of congenital heart disease is not genetically connection, but actually with the some of the patients, some of the mother could be caring about for the carriage from some of the congenital anomalies, especially also the risk in the woman with the diabetes is also very high. And when we have this antenatal cardiac screening, it's possible to do early in the pregnancy during the starting on the 20-21 weeks. I saw that Dr. Michova is here.
I hope that everything will run better.
Can you share your screen, please?
Yes. I'm actually sharing, but somewhere said that resume share. Okay, resume share. And I think that we are somewhere here. No little emergency. It's okay. So we have demonstrated that most of a lot of cases of congenital heart diseases could be diagnosed even in the first trimester, if not diagnosed, at least suspected. And another important topic.
You have not shared your screen yet.
Didn't?
No.
Okay. Let's do this then. Share screen. Is it okay now?
Yes, it's fine.
Okay. So the associated conditions, especially the genetical conditions, are a very important issue, because if the heart could be repaired, unfortunately the human genome cannot be repaired, at least nowadays. So well known is the association of certain cardiac diseases with chromosomal anomalies. Actually almost between 25 to 40% of children with chromosomal anomalies, they have cardiac disease. Well known is the association with AVSD, VSD with the Down syndrome. In almost 100% of the children with Edwards syndrome, there is some form of congenital heart anomaly, at least a ventricular septal defect. In trisomy 13, this accounts for 80%, and in Turner syndrome, 1/3 of children, they have congenital heart anomalies, typically left-sided lesions. The association of some microdeletions, for example, the George syndrome, Williams-Borders syndrome, is also very important, and that is why when we see a certain type of anomaly, especially conotruncal one, we always offer at least FISH screening for DiGeorge syndrome, optimally microdeletion analysis with MLPA. This is a genetic method. And with all stenotic lesions, we offer investigations of Williams-Beuren syndrome. Well known is the association of certain heart defects with single gen defects associated with syndromes. Noonan syndrome, Hawthorne syndrome, Alagille syndrome are good examples for that. Nowadays, after the completion of Human Genome Project, actually a lot of heart diseases are associated with non-syndromic single gene mutation. For example, NOTCH1, NKX2.5 are associated with ventricular, when the mutations are associated with ventricular septal defects. With the advancement of genetical techniques, smaller genome defects like copy number variant changes and single nucleotide polymorphism changes are associated with certain heart defects, especially when they are performed on children with unknown form of mental retardation combined with heart defects. So genetics do matter, and we see that in practice every time, every day nowadays. This is a classic example of a child with AVSD at 16 weeks. We can see here both valves inserted in linear fashion. We can see the central heart defects when the valves are opened. We can illustrate that defect in color, but not always the situation is so straightforward. For example, here is the same heart on the all three images, the same heart from the same image on the same day of examination. So on lateral four-chamber view, actually the heart, the four-chamber view looks quite normal. And only when we perform the apical four-chamber view, heart seen from the apex, from above, we can see that the valves are inserted in linear fashion. So this is a child with AVSD, and this finding prompted the genetic investigations through amniocentesis, and trisomy 21 was found, and this was the only finding in this child. So it is important. The heart anomalies are very, very important, and knowing their association with certain genetic condition is always important. Not always, as I said, not always the things are so obvious. Here we have a child with a very subtle VSD, perimembranous VSD. It is hardly visible, and it is a really, really tiny lesion with a very good postnatal prognosis. But nevertheless, this was a child with trisomy 21, and I mean, sometimes really minimal lesions can be associated with significant genetic findings. So when we see a VSD, especially probably except those small muscular VSDs which are never associated with chromosomal anomalies, or their association with chromosomal anomalies is very, very low. So for every malalignment VSD, for inlet VSDs, for perimembranous VSDs, we always quote a frequency of about 6% according to a recent paper of association with chromosomal diseases. So we offer at least karyotype in this situation. As I said, sometimes even minimal lesions like this small VSD are associated with significant chromosomal finding. This is a Cri-du-Chat deletion 5, deletion of the small arm of the 5th chromosome child, and this is the only finding in the heart in this case. And the other findings, this was a twin pregnancy and only one twin was affected. And actually, children with Cri-du-Chat, they have a very, very mild prenatal findings. So it is very important because most of the cases with chromosomal defects have some at least minimal cardiac finding. And this is a child with microdeletion 22q11, the George syndrome. The child has only this right aortic arch, nothing more. I would like to speak especially about a recent finding, which is called aberrant right subclavian artery in the prenatal life. According to our textbooks and all the papers, it is best imaged prenatally when you do the 3-vessel and trachea view and reduce the PRF. And when in this situation, if you have an aberrant right subclavian arch, it appears coursing behind the trachea from the apex of the V. And in the best situation, it is better to be confirmed with post-Doppler because sometimes some vein makes the impression of presence of ARSA, but it is not ARSA actually. So when we image the ARSA, according to recent papers and protocols, we are also obliged to offer at least karyotype because Ravichawi in 2011 found that there is a very high association with aberrant right subclavian artery and Down syndrome. But until that point, we have taken care of about at least 30 or 50 babies with aberrant right subclavian artery, and only one of them had trisomy 21. And in this baby, also a small VSD was diagnosed. So I personally do not believe that isolated ARSA makes the risk of trisomy 21, but this is the way we counsel our patients. If we see ARSA, it means that there is a strong recommendation for invasive prenatal testing. Another case of catch-22. Here we have a very small, we have a small VSD, and rather we have also hypoplastic aorta. It is, I think it is better seen on the next slide. Here it is. With tubular hypoplasia of the aortic arch, and this is also a case of the George syndrome. The woman unfortunately was at 25th week of gestation during the diagnosis, and according to the Bulgarian law, after reaching the viability, pregnancies could not be terminated. So unfortunately, this woman gave birth to a child with George syndrome, but she develops almost normally. I mean, the intellectual deficit is not so obvious, and she meets the criteria for her school age at the moment. So as a conclusion, I would emphasize that the fetal echo is a very important part of fetal anomaly scan. We cannot do without it. But for optimal results, a multidisciplinary approach is always needed. It includes at least pediatric cardiologists, consultation with a cardiac surgeon, because the pregnant patient has to know what are the surgical chances of a certain situation. Neonatologist who is confident in dealing with a baby who needs a prostaglandin application, extended ventilatory support. Human genetic counseling is, as I emphasized several times, is a very important part of our team, and an obstetrician for optimal optimization of time, mode of delivery, and whatsoever. Thank you very much for the opportunity to speak at the end of those exhausting 2 days, and hope it was interesting for you.
Thank you, Marina. That's a really brilliant presentation, never mind the technical problems. I would like to ask a question to be very sure for the audience. What is the first sign that we could find some anomalies of the heart? In which week we will be delivered the first fetal echo?
Well, as I understood, what are the first signs? I mean, when we scan anybody at 13 weeks, except probably for the hypoplastic left heart, it is always suspicion. I mean, that diagnosis like tetralogy of Fallot, double outlet, they cannot be very well discriminated, and especially if we speak about prognosis and everything else, and deciding if to continue or not, it is too early for prognosing anything, but nevertheless, this is a good time to perform invasive prenatal testing. As you probably know, some of the genetic tests, even the karyotype takes at least 1 week, so it is a good time to start the investigation. So I would say 12 weeks.
12 weeks, okay. This is for the first taken of the echo for the...
Yes, and according to the recent papers, the lower time limit is about 12 weeks plus 3 or 5 days. The heart has to be big enough.
Yes. And then it's 21, 22 weeks?
Yes, at 21, 22 weeks is a very good time for diagnosing and prognosis. I know that you normally, the cardiologists, work with very well with numbers. I mean, the Z-scores are very important, and the best time to make final conclusions is 21 weeks. So I would say between 20 and 22. But one has to have in mind that the cardiac diseases are not in stable conditions. Sometimes a case starts like tetralogy of Fallot and ends with pulmonary atresia, VSD, because the pulmonary artery stops to grow. So the things change. So when we discover an anomaly, it is extremely important to refer the patient to expert pediatric cardiologists to do the follow-up. So after we find something, the main work is done by pediatric cardiologists.
Yes, of course. Okay, thank you. Professor Lee, do you have any comments or questions? Professor Ho?
No, thank you. I think it's quite good to end with this topic, because all the problems start from fetal life, isn't it? So we should,
yes, they do.
We should encourage early checking and early identify and early management. Thank you.
Thank you.
I'd just like to say it's been a very, very interesting meeting, and I learned lots. Really like to thank you, Professor Hristova, for having us in here to join you all.
Thank you so much. So I think we are on the end of our course. If there's no any questions, I don't see in the chat anything. No, but anyone from our panelists, it's free to comment or to make something comments about during three days that we spoken about different topics on congenital heart disease in adults, how to manage, how to and follow up these patients, when to send to cath lab, when to send to intervention, when to send to surgery. I think everything was very quite interesting and very useful for everyone here. Professor Lee, from Professor Ho.
Yes, thank you, Professor Hristov, to organize this very important meeting. As I have mentioned from beginning, topic on this area is not very widely taught. So people are eager to learn, but opportunities are not plentiful. I think it's very important we have a meeting like this and emphasizing specifically on adults with congenital disease. Of course, we cover from the fetals to neonates to children and to adults. The problem was born when they were in fetal life. So we need to know why they have it. Then we can plan and we can treat them. So I think, thank you very much, Hristov, for organizing. I know 3 days, very long, but during this pandemic, if you manage to organize a course like this, it's a great success. Thanks for your hard working and patience sitting here, answer all the questions. I'm sure a lot of people have benefited from this course. And just another word is, so for congenital heart disease, especially adult congenital heart disease, it's become a very important topic. Imagine in the past, we're talking about pediatric cardiologists, but now the numbers are more in adult population than pediatric population. But if you think of specialists in ACHD, it's much, much less. So we need to train, we need to educate people, and people also need to learn in order to catch up, in order to offer the medical care for this very important group of patients. If you think the difference between pediatric and adult, when they were baby, they have a heart problem, they have their parents, they have their family to worry about it. But now when they grow into adult life, suddenly patients can feel very much lost, and they couldn't find a job, they cannot find insurance, they have a heart problem, they don't know what to do, what is the future. So being a medical staff, we carry a lot of duty. I think sometimes even more things we need to look after for the adult, not only just medicine, sometimes social life, boyfriend, girlfriend, children's, these are all very important. It's like you are part of their life. So I hope people realize this is such important specialty we are in now. And I hope we can do more and more this kind of educational program in the future. Thank you very much for everybody's patience and stayed until this hour. Thank you.
Professor Ho?
Well, I simply echo Professor Lee's views. I think training and education is particularly important with this growing field, rapidly growing field of ACHD. Absolutely.
Thank you so much. So I think that 3 days was going very fast for us, and I would like to give one small information about the participants. For these 3 days, we have registered more than 1,200 people, but really involved in the meeting was around 1,130 from 70 countries. This is the very huge amount from and huge interest about this meeting. I would like to thank you, especially Professor Lee and Professor Ho, because they was very enthusiastic and very helpful and make a very great success about this meeting. I would like to thank you also from on the behalf of the Foundation of Non-Invasive Cardiovascular Imaging in Bulgaria. that it's possible to make together this meeting together with Royal Brompton Hospital and Imperial College, and would like to thank for the special participation of the Professor Lee and Professor Ho, who is our distinguished lectures here in Bulgaria. They received this certificate of appreciation on the second day that we usually make early from the opening ceremony, but in this different time for our meeting, it's the program is going upside down, and I hope it was very helpful for everyone that was joining us those 3 days. Actually, their participation as part of this program from their position of expert in the field of morphology and echocardiography and imaging of adult congenital heart disease make this meeting priceless. I sincerely thank all of the lecturers from Bulgaria and all over because they give it all great contribution for scientific part meeting. I also would like to express my sincerely gratitude for all our sponsors, without whom that event will be not able even possible to do. And not at least, I would like